Yes, so plasma uracil is used as a screening test for DPD deficiency in primarily in Europe. It really isn't used very much in the United States. Um, and plasma uracil is not as well validated as other screening tests for DPD deficiency, especially as the genotype tests. So for that reason, genotype testing of the DPYD gene remains the most commonly used test in the United States. And there are some concerns that the plasma uracil test is variable from patient to patient institution. However, the advantage of the plasma uracil test is that it doesn't rely on knowing the specific DPYD gene abnormalities that you're looking for. So this as a phenotypic test, the plasma uracil has the opportunity to pick up on DPYD gene variants that are different from the typical or best known DPYD gene variants associated with DPD deficiency. Our hypothesis was actually that plasma uracil concentrations might help us identify patients who are at risk for being underdosed by chemotherapy. So while plasma uracil concentration is usually used to identify patients who are who have a high plasma uracil concentration and therefore are at increased risk for having toxicity from DPD deficiency, our hypothesis was looking at the other side of this, and we were trying to figure out do patients who have a low plasma uracil concentration, are those patients who might benefit from an increased dose of 5-FU because perhaps they are high metabolizers of fluoropyrimidine chemotherapy. So the study design of the study was to identify patients who are going to be treated with continuous infusion 5-FU, usually with the FOLFOX or FOLFIRINOX regimen. And then we did baseline plasma uracil testing of those patients under somewhat stringent conditions. All of those tests were collected in the morning after an overnight fast. And then we subsequently collected 5-FU PK data with cycles 2 and 3 of chemotherapy so that we have data both on their baseline plasma uracil concentration and also on any symptoms and side effects from chemotherapy and on the 5-FU drug exposure during the first couple of cycles of treatment. So the main finding was that we did not confirm our hypothesis. So the hypothesis that patients with the lower plasma uracil concentrations would be that would be a predictor of subtherapeutic 5-FU dosing. That was not confirmed, at least not at a statistically significant level. There was a weak association, and it was not statistically significant. So the main finding that was statistically significant was that women were more likely to have high drug exposure than men. So looking at the 5-FU drug exposure, female sex predicted a higher drug exposure, male sex predicted a lower drug exposure. So you can look at that in two ways. It either predicts higher risk of toxicity among women, or alternatively, perhaps it predicts a risk of underdosing the chemotherapy in men. It's not really the finding that we were specifically looking for. On the other hand, it's not entirely surprising either. Our study is a relatively small study with a total of 29 patients involved. There is certainly have been prior studies that have shown that women have higher risk of toxicity from 5-fluorouracil fluoropyrimidine chemotherapy in general. So that association of sex with toxicity risk is known, and we're kind of looking at the other side of this, which is not only do women have higher toxicity risk, but men have lower drug exposure, and those relationships all make sense. And the suggestion is, it's possible that men are actually being, I think that the side of this that is a little bit different, the angle that our study came at this from, was that perhaps the men actually might need higher doses of chemotherapy if it's true that that certain threshold concentrations are needed for optimal response to treatment. one wrinkle of the study that I haven't had a chance to mention yet is that we did, although the main objective was to look at the association between plasma uracil concentration and 5-FU drug exposure, we also looked at the ability of the plasma uracil concentration to help us identify new or unconfirmed DPYD gene variants associated with DPD deficiency. So I'm not sure that we'll be pursuing the plasma uracil concentration to try to identify patients who are at risk for being underdosed by chemotherapy. But we did identify one patient in our study who had what appears to be a novel allele associated with DPD deficiency, so a novel DPYD gene allele. And the way that we're able to identify that is by kind of triangulating with the plasma uracil. So even though plasma uracil concentration is not widely used as a primary screening test for DPD deficiency, there may be a role of the plasma uracil as a correlational study to be used together with DPYD gene sequencing, so that if we identify a DPYD gene abnormality that has an uncertain relationship to DPD deficiency, we can look at the patient's toxicity response, and we can also look at whether or not the plasma uracil concentration is suggestive of DPD deficiency. And in this case, the patient even though none of the patients in our cohort had standard DPYD gene variants, this patient had both the highest plasma uracil of all the patients in our cohort, and also had a novel DPYD gene variant that appears to be a DPD deficiency variant.